FAVMI presents Unfolding Mental Illness, hosted by Saraswati Suresh.
Hello, everyone. FAVMI, Family's Voice on Mental Illness, is back with its 19th episode. We are also the Western Zone of Families Alliance on Mental Illness, FACE-ME. Through our episodes, we hope to reach family carers who are looking after their loved ones living with mental health disorders or the persons with mental illness to learn more about mental health and help them with certain tools and resources. If you are a family carer or a person with mental illness seeking advice, guidance, and understanding, please do subscribe to our YouTube channel at favme.in. I am Saraswati Suresh, founder of FAVME and the host for today. And I have my co-host, Dr. Sachin Ganokar, who is the founder, member, and director of FAVME. This is our 19th episode, and our topic is anxiety and depression. Anxiety and depression are amongst the most common mental health challenges, yet they remain deeply misunderstood. So through this conversation with our guest today, we hope to explore the understanding, the science behind these conditions, and the importance of seeking support and when to seek support. Our guest for today is Dr. Alok Kulkarni, who's a senior consultant and an interventional psychiatrist based at Hubli in Karnataka. He's completed his post-graduation in psychiatry from NIMHANS. He has been awarded his post-doctoral fellowship by the Center of Excellence in Mood Disorders based at the University of British Columbia, Vancouver, Canada. He is the recipient of the prestigious IMH Marshall Fellowship Award for the year 2022-23. As a part of this award, he has researched bipolar disorder and a difficult-to-treat depression under the mentorship of Professor Lakshmi Yatham, a world authority on mood disorders. He's also acquired specialized expertise in the use of intravenous and oral ketamine therapy for difficult-to-treat depression. He's a member of the Royal College of Psychiatrists of the United Kingdom and has significant experience in using non-invasive brain stimulation such as the transcranial direct current stimulation, the repetitive transcranial magnetic stimulation, and ECT. He also consults at the Manas Institute of Mental Health and Neuroscience, a state of art for excellence in mood disorders. Welcome, Dr. Alok, and it is our pleasure to have a conversation with you, sir.
Thank you, Saraswati, for the very kind introduction. Hello, Dr. Ganorkar. Many thanks for having me here and thanks for the opportunity. I look forward to interacting with you.
Thank you very much, sir. Doctor, let's start this conversation with the very basic of understanding what is anxiety and depression, because most of us in our day-to-day lives, use this vocabulary, saying, I'm depressed, I'm anxious, I'm sad, very trivially. And, for a layman, it doesn't, we really don't understand what is the actual gravity of that wordings, what we are using. And when is the time when actually one has to, move to seek help, go to a doctor or a psychiatrist or a counselor?
Right. That's a very important question because in this day and age, so in the age of influencers, it's very easy to label someone as an anxious neurotic or someone who is merely feeling sad in response to a life stressor as being depressed. So it's critical to understand these concepts. So anxiety is defined as the fear of apprehensive fear of future misfortune or danger. And that is associated with bodily tension, bodily distress, and other physiological changes in the body. Fear and anxiety can be seen from an evolutionary perspective as well. And these symptoms can be seen as adaptive responses. To make it very simple, fear is a normal emotional response to imminent threat. And fear is associated with the fight or flight response. You either take the situation head on or you flee from that situation. So if there's an imminent threat, for example, I see a tiger right in front of me. So it's quite natural. It's quite physiological to experience fear in that particular context. Anxiety, on the other hand, is an exaggerated fear or fear about an event that is yet to occur. So that is how you differentiate between anxiety and fear. And was your second question on how to differentiate this from depression?
Depression, yes.
Right, right. So in response to life stressors, for example, loss of a job, bereavement, or separation, it is but natural to feel sad. But that is very different both qualitatively and quantitatively from clinical depression. Depression is a state wherein a person has persistent and pervasive sadness of mood, energy, and activity levels. While talking about depression, one always tends to talk only about mood, but in depression, there is a pathological alteration in three aspects. One is mood, second is energy, and third is activity levels. So if this state is accompanied by other symptoms as well, such as hopelessness, worthlessness, inappropriate guilt, I mean, thoughts about dying or wanting to die, uh, biological functions being disturbed, such as disturbed sleep, disturbed appetite, having no hope about the future, then, and if these symptoms last on a day-to-day basis for a period of weeks to months, then we can say that that person is clinically depressed. Merely feeling sad in response to life stressors cannot be called as clinical depression.
Okay, so when it lasts for more than a week to couple of months, that's when they actually come and meet the
So
doctor.
again, I'm very skeptical about all these timelines that are mentioned
Okay.
in various classificatory systems, and it's not just me. I mean, various psychiatric bodies all over the world are now contesting these timelines because they are quite arbitrary in nature.
Okay.
So it should, yes, our classificatory systems do say that all these symptoms should last minimum for a period of at least 2 weeks. So what if a person has these symptoms only for 13 days? So that becomes quite tricky in that context. So one will have to look at the holistic picture. Is it causing clinically significant distress? Is the person's socio-occupational functioning being affected? What about the pervasiveness of these symptoms across contexts? What about the severity and intensity of these symptoms? How frequent are these symptoms? And what about the duration of these symptoms? And finally, is the person's functioning being affected as a consequence of these symptoms? So we'll have to look at all these aspects and then take a call on whether the person is clinically depressed or not.
Okay. So how different are these then from mood disorders? Are they part of it, or is that just a, you know?
Right. So yeah, you can complete the question, then I'll.
No,
Yeah.
so what I want, I mean, are they part of the clinical depression, or they are a separate category altogether?
Right. So I was elaborating on depression because you had asked me how to distinguish between depression and
Anxiety, yeah.
So even under anxiety, we'll have to sort of understand them in depth. I'll come to that in a moment's notice.
Yeah.
Until the last part of 19th century, anxiety and mood disorders were clubbed together under one broad rubric. It was Freud in 1895 who asked for a separate classification of both anxiety and mood disorders. In fact, in the year 1895, Sigmund Freud introduced the term anxiety neurosis. And this term included people with phobias and panic attacks. He then introduced another term called anxiety hysteria. While anxiety neurosis had people or patients with psychological problems, anxiety hysteria had people with both psychological and physical symptoms. So if you look at it very broadly, the up the hierarchy is mood disorders, and anxiety disorders can be a part of mood disorders. Mood disorders generally include depression and bipolar disorder. But now that the classification systems have separated out, mood disorders and anxiety disorders are separate classifications, but they can occur together. They frequently co-occur, and anxiety and mood disorders can be seen in the same person as well.
Okay. So they also are a part of serious mental disorders like schizophrenia and bipolar, etc.
While they are common and they're quite serious by themselves, traditional sense of the term, they do not come under the term of severe mental illness or serious mental illness. Generally, that includes bipolar disorder, schizophrenia disorder, and schizophrenia spectrum disorder. Sometimes severe OCD can even sort of come under that, but generally anxiety and depression per se are not included in the term severe mental illness or serious mental illness.
Okay. But they can be a part of the other illnesses.
Absolutely, absolutely. So anxiety and depression are pervasive across psychiatric disorders. So the field is generally moving towards trans-diagnostic classification, that is working in symptom clusters. The symptom of anxiety and disturbance in mood can be seen in anxiety disorders per se, in depression per se, as well as the SMIs or substance misuse. So
okay. So anxiety and depression, are they do these happen because of the genetic concept, or is it because of the environmental influence today, or the psychosocial factors? What is more prominent today?
Right. That's a very important question as to why these disorders happen. So I would want to give a more holistic picture, a more broad picture of psychiatric disorders, so that our viewers can understand as to what causes these disorders in the first place. So as with any psychiatric disorders, there are a couple of things at play. First, we can view it through a couple of lenses. The first lens is viewing it through the lens of stress and childhood adversities. The second lens is viewing it through the field of genetics and gene environment interactions. And the third lens is viewing it through the lens of cognition and circadian impairment or impairment in the body's internal clock. Although this third lens applies more to mood disorders such as depression and bipolar disorder. Now let's focus on the first two aspects: stress, childhood adversities, genetics, and gene environment interactions. So let's break it down one by one. So what are stressors? So there are major life events such as loss of a job, bereavement, separation, losing one's parent before the age of 11 years, and so on and so forth. These are all extremely stressful events, right? And a change in emotional response, change in behavior is but natural and is expected to these life stressors. But increasingly, research has shown that those people who have had adverse childhood experiences in the form of childhood neglect, childhood maltreatment, childhood abuse, either physical abuse or sexual abuse, they are at an increased risk of having later onset psychiatric disorders. It can be anxiety disorders, mood disorders, or even severe mental illness. So we cannot discount the fact that adverse childhood experiences, or ACEs as they are commonly known, are a predictor, sure shot predictor of later onset psychiatric disorders. Now, through these disorders, through these stresses, each of us develops our own strengths, our own capabilities, something called resilience to face these major life events. This resilience varies from person to person, and that in fact serves as a protective factor against future episodes. So first one is stress. Now, let's take a person who has had a very stable childhood and a person who has gone through these adverse childhood experiences. The propensity, likelihood of a person who has had ACEs to develop an anxiety disorder is definitely higher as compared to the person who has had a very stable childhood. So that is one lens. Now, coming to the discussion on genetics and gene environment interactions. So all genetic studies have occurred in the context of family studies, that is, studies conducted in people who have multiple family members with mental disorders, as well as monozygotic twins. So studies conducted on monozygotic twins, the so-called concordance studies. Now, what happens is the field is now moving towards gene environment interactions, that is the interaction between these genes as well as the impact of environment on the onset of these psychiatric disorders. Now, while discussing these studies, we talk about something called as heritability. What is heritability? It refers to the extent to which these disorders can be explained by variation in genes. For example, let's take the example of anxiety disorders. To what extent can we attribute the current clinical presentation to the genetic predilection of that individual? So that is called heritability. Now we also talk of a concept called heritability estimate. And please let me know if it is getting too technical. I can really tone down on
No,
that.
it's very interesting. You can carry on.
Okay, okay. So when we talk of heritability estimate, we talk of a number of 30 to 40% for anxiety disorders, meaning that around 30 to 40% of anxiety disorders can be explained by genes alone or by our genetic predilection alone. So what about the remaining 60%? There comes the vital role of environment. And when I talk about environment, I talk about all the stresses that we have discussed: childhood neglect, childhood maltreatment, abuse, so on and so forth. So now studies have shown that these genetic factors or genes reciprocally interact with each other with these environmental exposures along with random factors. So the clinical, when I see a patient in my clinic, the clinician will have to think about the pathways that have led to the current clinical presentation, right from the genes to through intermediate phenotypes that are very poorly understood at many levels. So finally, you have a person who is sitting in front of you with features of anxiety disorder. So this is a broad understanding of genetics, gene environment interactions in which are associated with psychiatric disorders. And here I would like to remind the listeners that we are talking about association, we are not talking about causation, because psychiatric disorders per se have multifactorial causations, meaning there's not one single cause that has resulted in a clinical presentation. For example, we have not been able to identify a single gene that is responsible for the current clinical presentation of an individual. So there are multiple factors that are associated with psychiatric disorders. And finally, all these disorders can be seen in the light of evolution. There is nothing that makes sense without, I mean, if you don't view that in the light of evolution. I mean, these are all adaptive responses, so to speak. For example, our ancestors had to have some amount of anxiety to protect themselves from all these wild animals. And if there was no fear, if there was no panic, our species would not have survived. It's just that those threats have gone, but our body's response still remains in the form of an evolutionary response. And in response to day-to-day stressors, today's stressors may be different. It may be fear of missing out, it may be continuous smartphone usage, it may be comparison with our peers, but our body is tuned to respond in the same manner. So this is the broad understanding of why these disorders happen.
Okay, that's very beautifully explained. What about the use of cannabis and overusage of social media and things like that?
Right, right. So all these fall under the rubric of environmental exposure.
Environmental exposure. Okay.
So cannabis has a definitive role in being associated with a lot of psychiatric disorders. Now, just to digress, now increasingly there is emerging line of evidence that heavy cannabis usage predates the onset of schizophrenia and schizophrenia spectrum disorders in a genetically vulnerable individual. There's no doubt. This was a huge area of controversy earlier, whether cannabis independently causes psychosis or is it associated with psychosis. The broad understanding was cannabis predated the onset of schizophrenia in a genetically vulnerable individual, but increasingly research has shown that heavy cannabis usage definitely is sort of associated with many psychiatric disorders, including anxiety, mood disorders, and schizophrenia spectrum disorders. Now, as far as smartphone usage is concerned, behavioral addictions and all, will require a separate discussion altogether.
Discussion altogether.
Yeah. But broadly, what I would like to emphasize is that the coping strategy keeps differing from individuals. For example, we call this cognitive attributional style. Let's say that I'm faced with a stressor, for example, bereavement, and how I respond to that, how I process that varies from my capacity to process that stressor and my capacity to respond to that stressor is significantly different from another person. We are all unique in that strength, and therapy will sort of have to look at maximizing our strengths and minimizing our vulnerabilities. So that is precisely what happens in therapy or in cognitive behavioral therapy. So if I'm constantly on the phone, constantly looking at what other individuals are doing, how they are outperforming me, it definitely serves as a stressor. While we were growing up or while you were growing up, I think we spent a lot of our time playing outdoors. That enabled a lot of social connections. That enabled a lot of change in our brain structure and function, because interacting with others in a social environment is stressful enough for our brain, and it will sort of rewire its neural pathways. Now that is completely missing in today's age, day and age, wherein we see our children constantly being hooked onto phones without real in-person interaction. So yeah, that definitely has some association. Now, to what extent and all, it needs to be scientifically answered through larger studies, through larger replicable studies.
Yeah, I loved the statement you made of maximizing our strength and minimizing our vulnerability. I think that's an excellent takeaway for me at this moment. Yeah. My next question would be, what is the myth around anxiety and depression today?
Okay. So yeah, there are a lot of myths surrounding anxiety and depression. For example, people might just say that even if the person is having a clinically diagnosable condition, disorder with significant distress, people might just brush it under the carpet saying, oh, you can just jump out of it. Have a positive attitude. It's all there in your mind. So these are all very casual statements to make about a disorder that can be very, very disabling. It's just, although it is branded as a common mental disorder, it may not fall under the rubric of severe mental illness, but the disorder in itself can be quite disabling. Let's take the example of a person who has panic attacks.
Yeah.
So panic attacks are attacks wherein you have sudden unexpected surges of anxiety, and there's a sudden onset. This anxiety peaks within 10 minutes, and the whole attack per se can last anywhere around 35 to 40 minutes. Now, imagine what that person will go through during these 35 to 40 minutes. There will be palpitations, autonomic symptoms, fear of dying, impending sense of doom, choking sensations, derealization, depersonalization. As in, when I say derealization, the person feels as though the external environment has changed. And when I say depersonalization, the person will feel divorced from his or her own self, and the external world appears falsified or distorted. Imagine all the sensations that can be very, very distressing to the individual. So you can't brush it under the carpet and say that it's all in your mind. So this might be an individual who has genetic vulnerability, a family history of mental illness, is now faced with a stressor, and now has a clinically diagnosable anxiety disorder. So this is a very common myth that I see in my day-to-day practice. I would like to hear some of the myths that you or Dr. Ganorkar might have encountered around these disorders.
Well, to me, it's the lack of empathy which falls. And from a family carer, I would say that, people desert you,
Right.
saying that, it's all in your head and there's nothing wrong with your loved one. You are making big you and cry about it. And, not being part of the art journey and giving us the support. So I think that for a family carer like us, I think we expect a lot from our own inner circle at that point of time, to be with us, to bring more resilience to us. So
Right.
I think that myth is to be, that no, yes, just like the person with mental illness is going through a phase, we are also going through a similar phase, I would think.
Right.
Yeah.
And sort of broadly explain about the type of anxiety disorders that are commonly seen in clinical practice.
Yeah.
And how it is important to differentiate between these. And at any moment, you can sort of ask me other questions.
Sure.
Yeah. So broadly, so as I was talking about Freud, he classified anxiety disorders into phobias and panic attacks, and we just had a discussion about panic attacks. Now, what is commonly seen in clinical care settings, primary care settings, is something called generalized anxiety disorder. The crux of this disorder is excessive worry. And this worry generally tends to last for more than 6 months. Core of generalized anxiety disorder is excessive worry lasting for more than 6 months. And these worries are diffuse in nature. They are not restricted to one particular theme or to one particular social encounter. For example, I might have this worry that I will lose my job. In the morning, my worry will be about my job. But as the day progresses, I'll start worrying about my mother's health. Oh God, what is going to happen to my mother? Will she fall ill? So these worries are diffuse, not restricted to a single theme, and not restricted to a single social encounter or to a single context. So this is called generalized anxiety disorder. Now it is important to differentiate it from other types of anxiety disorder. Now, the other commonly encountered disorder is panic disorder. Panic disorder has two components to it. One is recurrent panic attacks. And once you start having panic attacks, you develop this tendency to fear the recurrence of these panic attacks. So this is the two critical components of panic disorder. So, and we have had the discussion on panic attacks.
Yes.
So the other common anxiety disorder that is seen in clinical practice is social anxiety disorder, wherein the person will start to have fears about intense social scrutiny, being evaluated in a negative manner, to such an extent that that person will start avoiding social situations altogether. So, I have had individuals who sort of take a shot of alcohol or a drink before a social encounter to cope with that social situation. So substance misuse is very, very common in both mood and anxiety disorders to cope with those distressing situations. Finally, we have something called separation anxiety disorder, wherein there is a fear of losing major attachment figures. For example, losing one's parents, losing one's close friends, etc. Although these fears are prevalent in generalized anxiety disorder as well, in GAD, what happens is that the theme keeps varying. Whereas in separation anxiety disorder, the theme is always about losing one's attachment figures. So these are various anxiety disorders. Because you did ask about anxiety and how it is different from a diagnosable clinical condition. So at least if our viewers are aware of these terms, then probably they will sort of be able to relate more to it.
Yeah, sure. I think that was wonderful of you. Yeah.
Right.
I'll now hand it over to Dr. Sachin to take it forward.
Right.
Thank you, Saraswati. Thank you for the wonderful discussion. Thank you, Dr. Alok, for actually throwing light on so many important points, and it has actually helped us a lot to understand what happens in anxiety and depression. Based on the earlier discussion, mind is an invisible organ. So, as a psychiatrist, and for us caregivers, as Saraswati rightly mentioned, people think that our pain doesn't exist and the burden doesn't exist, and also the suffering of the people whom we are taking care of also doesn't exist. So either it's very imaginary. So I think that is what the main trouble is in that sense. So I just wanted to continue the discussion by asking what are the current treatments for anxiety and depression in terms of medication, psychotherapy, and lifestyle modifications. If you could please throw light on this, and also how one could address stigma while treating these disorders.
Right.
Thank you, Doctor.
Yeah, thank you, Dr. Ganarkar, for those very important questions. Before I dive into the treatment aspect, you mentioned about the burden of these disorders and how it is underrated. Now, if you look at the prevalence rates of stress-related and neurotic spectrum disorders, it is around 3.5% in India. That is a huge number. If you work it out, look, 3.5% of India's population is a huge number. It will run into lakhs, and so many individuals are affected with anxiety disorders. And now coming to the treatment of these disorders, generally treatment of any psychiatric disorder happens under three headings. The first one is biological treatments. The second sort of treatment is psychological treatments, and third treatment is social treatments. Biological treatments include medications and neurostimulatory approaches. Neurostimulatory approaches generally do not apply to the field of anxiety disorders unless they are accompanied by severe depression, etc. So, and when we talk about medications, we have umpteen number of options. I will not go into the specifics of these because that may not be of much importance to our listeners. Suffice it to say that very safe and effective molecules are available in today's day and age. One of the worries that I commonly see amongst carers is, are these medications addictive in nature, and will I have to take them lifelong? Absolutely not. These are very safe and effective treatments. You do not have to take them forever. Generally, a slow taper is made after you are put on these medications for a period of 6 to 9 months or 9 to 12 months. No responsible clinician will give you these medications beyond that time frame. And while there's a class of medications called benzodiazepines, which are used in the shorter term, say for 1 to 2 weeks or for a maximum of 4 weeks. Definitely, benzodiazepines are addictive in nature, and they should not be given for a period beyond 4 weeks. If taken continuously beyond 4 weeks, then they are addictive in nature, and then weaning off the patient off that becomes a big issue. And that's a big issue in anxiety disorders as well. To sort of address the anxiety immediately, we see that patients are put on heavy dose, high dose benzodiazepines for months together. So that is a very unfortunate thing to happen. I would sort of encourage our listeners to actively talk to their psychiatrists, to their clinicians, and ask their doctors that if benzodiazepines are necessary, please take them for a period of 1 to 2 weeks and then make a slow taper and stop. So that is one of the issues that I would want to bring to the table. So then in the longer run, you have antidepressants, anti-anxiety molecules. So coming to the more relevant aspect, psychological treatments, there's a wealth of evidence to show that psychological treatments are sufficient in mild anxiety disorder. For example, if it is mild anxiety of recent onset in response to a stressor, you don't actually require any treatment. You don't even require psychological treatment. Once the stressor abates, once the stressor resolves, these transient symptoms of anxiety come down. So we think of treatments only if it is moderate to severe anxiety, and there are clinical grounds to decide whether it is moderate to severe anxiety. We take a host of factors into consideration. For example, the duration of symptoms, the severity or intensity of symptoms, the frequency of symptoms, how pervasive are the symptoms in a given context, or how disproportional are these symptoms in a given context. Are they occurring in every context? And is it causing distress that is impairing with the client's functioning? So these are important factors to consider to decide on the necessity of treatments. A lot of times what I see is anxiety disorders particularly are over-treated when it is not required at all. And somewhere the concept of treating anxiety disorders, for example, let's take the example of panic disorders or panic attacks. The client, we will have to equip the client to deal with that distress so that his or her brain or mind get conditioned to tolerate that distress. So this is precisely what happens in systematic desensitization, wherein we sort of for a client of phobia, we set up a hierarchy of stimuli which will evoke anxiety, and then gradually expose that client to those anxiety provoking stimuli so that the client learns to tolerate those distresses. And once there is rewiring of these neural pathways, the client will be able to respond to those threatening stimuli without experiencing physical or psychological symptoms of anxiety. So one of the things that I would want to emphasize is that recent onset mild anxiety in response to a stressor need not be treated. We also need to keep in mind that anxiety disorders are frequently over-treated, and we need to sort of tap into the client's strengths and not just look at mere medication management. This other psychological treatment that is commonly employed is cognitive behavioral therapy. It has two components to it. One is the cognitive part, and second part is the behavioral part. This generally involves 5 to 20 sessions, and these sessions happen on a weekly basis, and each session lasts for 35 to 40 minutes. So negative or faulty patterns of thinking are identified. For example, I might think that I only have weaknesses and no strengths whatsoever. The therapist will identify this faulty pattern of thinking. The therapist will then point out to me that, yes, I have enough strengths that I can capitalize on, and gently will try to restructure my thinking pattern. So that is the essence of CBT. Then finally, we have family intervention, social interventions, wherein the entire family is educated about the nature of the illness, about the possible course of the illness, and how they can support the client during during a crisis. So these are the broad interventions that are available for the treatment of anxiety disorders.
Yeah, thank you, doctor. So based on the earlier discussion, what Saraswati was asking, like you mentioned rightly that there's a debate on the duration of what could be anxiety depression in terms of number of days and number of months.
Right.
So when you are in a workplace or you are in a family setting,
Right.
and people commonly use the vocabulary saying that I am depressed or I'm anxious. So how do you sensitize people in the workplace or in the family that this could be a disorder and a help could be sought? So how do you actually explain in that sense? And also the most important part is stigma of how do you accept that disorder and build coping skills in the family as well as in the society.
Right. And you have raised a number of important points. I'll talk about stigma, I'll talk about resilience, and I'll talk about how the distinction between mere sadness and clinical depression. So depression, as I was elaborating earlier, has certain core components. The core component of depression is something called anhedonia. Hedonia refers to a feeling of pleasure. So anhedonia is complete or total loss of pleasure. So anhedonia defines clinical depression. The person, someone who enjoy day-to-day activities such as talking to uh, one's family members, talking to one's friends, watching television, going out to play. So the person loses absolute interest in these day-to-day activities. So anhedonia is a loss of pleasure in activities that were previously enjoyable. So that is at the core of depression. And that is also accompanied by persistent and pervasive sadness of mood that lasts throughout the day or for most part of the day. So, and this also has other symptoms: easy fatigability, disturbed biological functioning, sleep and appetite going for a toss. There's hopelessness, worthlessness, inappropriate guilt, suicidal ideation, crying spells, pathological guilt, and so on and so forth. Along with this, there's a pathological alteration in the person's energy and activity levels. So now, if we look at all these symptom domains, and if these symptoms last for weeks to months, then you can say that that person is clinically depressed. I have had an interaction with my boss. Boss is not in a good mood, says something that is hard, that is not palatable. I feel sad in response to that. I cannot call myself that I'm clinically depressed. I might say that yes, I did feel bad. I did feel depressed in the sense that the English language has this usage, has this word called depression, but that is qualitatively very different from a mood disorder or from clinical depression. Now coming to the question of stigma. So stigma surrounds psychiatric disorders. So stigma surrounds every aspect of psychiatry and psychiatric neuroscience. The only way to counter this is to sort of normalize it by saying that there's no health without mental health. Mental health is as important as physical health. And nowadays, we have seen that a lot of people in the public domain are coming and saying that, yes, I have a diagnosable anxiety disorder, I have a diagnosable mental health condition. That definitely sort of lends credence to the fact that conversations can happen around mental health. It is not something to be brushed under the carpet. So we'll have to advocate for mental health. It needs to happen at various levels. It needs to happen at the level of NGOs. It needs to happen at the level of public personalities coming out and talking about mental health challenges and difficulties. It's also important to distinguish in this context between mental health, mental illness, and mental disorders. So it's important to normalize discussions surrounding mental illnesses. What has happened is a lot of discussion has started to happen surrounding mental health and mental health disorders, but we also need to talk about severe mental illnesses and common mental disorders. We need to talk about anxiety and mood disorders. We need to make it sort of more visible. Efforts are on post-COVID, but a lot more needs to happen. It is too little and too late, in my opinion. Yeah.
Thank you, doctor. Thanks a lot. I think the word which I think Saraswati and you had mentioned, it's very casual. People take it very casually that if you mention that there's a mental health disorder,
Right.
and most of the times people don't want to do anything about it.
Right.
So I think that's the question. And we were, as a caregiver group, we are debating the budget right now, and the kind of money it is being given to the mental health sector.
Right.
One of the last questions we wanted to request you is that how can technology help people in our country, where we have a population of roughly 150 crores? How can actually technology and mental health come together to create awareness and maybe help people accessing treatments, and maybe family groups like us who
Right.
want to build coping skills and want to address our own reactions in a much better manner, and also help our loved ones who are suffering from mental health disorders?
Right. Yeah, so technology is increasingly playing a role in the delivery of services, be it psychotherapy or be it just a clinical consultation. So a lot of discussion is going around the hub and spoke model, because anxiety disorders generally come to the attention of the primary care physician. So at the level of at the taluka level, you may not necessarily have a qualified mental health professional, either a psychologist or a psychiatrist, to deal with these disorders. So the discussion is now around the hub and spoke model, wherein a mental health professional sits at the hub and guides the primary care physicians who are sitting at these spokes at the village level, taluka level, district level, and so on and so forth, to sort of fine-tune the diagnosis, to offer first-line treatments for common mental disorders. So that is one level where technology can play a role. So that is at a broader level. Now, at the more individual level, we have seen that there are a lot of apps that have cropped up that can offer counseling services, psychology and psychotherapy services. So there's no doubt that technology will continue to play a role in mental health. But at the end of the day, all these endeavors are human endeavors. So the human element cannot be sort of removed from these technological applications.
No, thank you, Doctor. Thank you, Doctor. Thanks a lot. I think that was a very good. And also, do you have any any message for us caregivers? Like how can we actually be better organized in a certain sense, and also look at the various demands and what we want to actually help the people who suffer from mental disorders. Is there a way in which we can help psychiatrists deliver better care and outcomes? So, do you have any expectations from us, or is there a way in which an ecosystem can be built where people who live with anxiety and depression can be helped in a much better manner?
Right, right. So caregivers go through their own share of stress. There's significant caregiver burden. There's absolutely no denying that fact. But some families may be very new to these terms, to these disorders. We are all very tuned to discuss, to know about physical disorders. For example, I wouldn't, let's say I have a family member who has diabetes. I wouldn't tell that family member, it's all in your mind, just come out of it, use your willpower and come out of it. So to a person with panic attacks, to a person with panic disorder, or any anxiety disorder, or for that matter, any psychiatric disorder, it can be shattering to hear those words. So we can be cognizant of the fact that it is a brain disorder. There are two elements to it, and that person is not doing that thing on purpose. Empathy plays a great role in sort of coping with these disorders. Point number one. Point number two, quality of life improves drastically by leaps and bounds if right care is given at the right time. And point number three, it's not, we all carry these diagnostic labels. You need not, that cannot become one's identification. Above and beyond one's, let's say I have anxiety disorder. Above and beyond my anxiety disorder, I have my whole persona. So we need to sort of pay attention to that. We can just club these. So yes, I have ischemic heart disease. In the same way, I have an anxiety disorder. So what's the big deal about it? So we'll have to we need to start looking at these things from these perspectives.
No, thank you, Dr. Alok. Thanks a lot. And I think I and Saraswati would like to thank you from the bottom of heart, and it's to talk about this because these are very general. They seem to be very general conditions because they are almost used as a vocabulary in a day-to-day talk, but they cause significant disability for people because, as you rightly mentioned about generalized anxiety disorders, maybe depression, clinical depression, where people actually are not able to function properly. So thank you very much for your time in your clinical practice and your schedule to, and also the kind of family challenges you have faced in the last few months to come and take out time and actually discuss with us. So thank you very much from me, Saraswati, and family, and our group of entire family carers. Thank you, Doctor.
Dr. Ganarkar, for having me. Thank you, Saraswati, for giving me this opportunity. I am delighted at the kind of work that FAMV is doing. I look forward to seeing more of your work. We'll be very happy to show you our work if you ever happen to find yourself in Karnataka. And I look forward to following your channel on YouTube. Yeah.
Thank you so much, Doctor.
Thank
Totally
you.
appreciate it.
Thank you.
Thank you.